Good morning, everybody. All my previous speakers have made my talk very easy. So hopefully I'll do it faster because it's a very huge topic. Obstetric emergencies cannot be covered within 15 minutes. So whatever has been already told, I'll skip them so that it becomes much easier. So my topic for today is obstetric emergencies, scissors and smarts. The heading itself highlights what it means. So it needs quick thinking and safe cuts in critical moments. Why does this matter? See, the maternal mortality rate as per UN records of 2019 to 21, it was 97. So it was India ranked second globally in maternal deaths, reporting around 19,000 fatalities in 2023. So, and it is just next to Nigeria. So maternal mortality remains high, and in this, emergencies are sudden and unpredictable. So scissors means we have to be surgically prepared. Smarts include your anesthesia vigilance and teamwork, which saves these lives. So primary goals, primary anesthetic goals, what do you have to have when you anesthetize these patients? One is maternal stabilization. Next is fetal well-being, rapid and safe anesthetic technique, monitoring and access, multidisciplinary coordination, and early activation of massive transfusion protocols if required, and post-operative care. So in detail, I'll go in with each of one of them. With, in a broader perspective, pre-anesthetic evaluation is very important. They assess the maternal condition, airway and fasting status, review the lab reports, assess fetal well-being, review imaging with USG and echo, explain risks, and obtain informed consent, which is very important. Next, coming to fluid and blood management, always have two large IV bore cannulas, and always keep blood cross-matched, warm fluids. If cell salvage is available, keep it ready. Maintain normothermia. What is your target? Target should be HB of 8 grams per cent, platelets of 75,000, PT-APTT less than 1.5 of normal, and fibrinogen above 1 gram per deciliter. So intraoperative role, call for senior help or help as early as possible. Communicate with the obstetrician to know about ongoing loss, and rapid sequence induction for all general anesthesia and unstable patients, and maintain normothermia and prevent coagulopathies. So monitoring is very important. Positioning, keep always supine with left lateral tilt and keep the patient warm. For whenever there is massive hemorrhage, when there is more than 1000 ml of blood loss, oxygenate the patient, rapid IV fluids with blood warmers, avoid slow transfusion filters. So always watch for complications when you are giving blood transfusions for hypocalcemia, hyperkalemia, citrate toxicity, and DIC. Don't wait for the lab reports for treating DIC. Special considerations may be for interventional radiology, cell salvage, and if there is refractory bleeding, think of recombinant factor 7A if available. Antifibrinolytics, tranexamic acid has to be thought of as early as possible within 3 hours of PPH. So fetal resuscitation, maternal resuscitation is always equal to fetal resuscitation. So monitor fetal heart rate continuously, maintain adequate uteroplacental perfusion. So depending upon the urgency of anesthesia, the Obstetric Gynecology Society has classified urgency of cesarean section as category 1, 2, 3, and 4. We are more worried when in category 1, where there is immediate threat to the life of the mother or fetus, like indications may be placental abruption, uterine rupture, severe fetal distress, cord prolapse, etc. So 2 and 3, you have some time, that is 10 to 15 minutes, so that you can optimize to whatever extent possible. So again, the decision of regional anesthesia versus general anesthesia depends upon the urgency, upon the existing epidural, and the maternal condition, if the maternal condition is stable or unstable, airway risk factors, because most of these pregnant patients have anticipated difficult airway, especially in cases with preeclampsia and eclampsia. And in fetal conditions where there is cord prolapse, you can't think of giving a regional block, go for general anesthesia, and the resource and skill of the anesthesiologist. So key points are: use regional if safe, fast enough, no contraindications. GA for immediate threat, severe compromise on contraindications to regional. Always balance urgency, maternal condition, airway and fetal status. Safety, minimize risk of aspiration, failed intubation versus hypotension or incomplete block. So again, preoperative preparation, fetal oxygenation is important. Give oxygen, give acid aspiration prophylaxis, prepare for difficult airway, position as I already mentioned. Pre-oxygenation, along with now rocuronium is increasingly used as an alternative to succinyl choline with the availability of Sugammadex. So short-acting opioids like remifentanil, fentanyl are considered safe and with minimal risk of neonatal respiratory depression, especially in eclamptic patients. In preeclampsia and maternal cardiac disease, careful opioid use is considered. These are the algorithms for safe obstetric general anesthesia, and these are from the, you think of rapid sequence induction in all this, these are the algorithms given by Obstetric Anesthesia Association, and we have the IDA guidelines as already Dr. Sumalata mentioned from 2016. So when you think of rapid sequence intubation, in case of difficulty, cricoid pressure must be reduced or removed. Induction with thiopental and suxamethonium still prevents anesthesiology practice, but research favors propofol with high-dose rocuronium with Sugammadex backup for reversal of neuromuscular block in case of the need for awakening. And after administration of the induction drugs, bag mask ventilation with inflation pressures not going above 20 centimeters of water is now recommended to reduce oxygen desaturation during intubation. So insufflation of 15 liters of oxygen via nasopharyngeal airway catheter during laryngoscopy increases the time to desaturate, and it is recommended in obese patients. And new algorithms recommend intubation with a video laryngoscope, especially in morbidly obese patients and during failed intubation. So these are the master algorithm, and this is our IDA protocol algorithm for unanticipated difficult tracheal intubation in obstetrics. So always consider supraglottic airway devices and maintain oxygenation. Rescue, if it fails, rescue face mask ventilation. Complete ventilation failure, then think of emergency cricothyroidotomy. And if all this fails, then think of peripartum cesarean delivery. So what are the major obstetric emergencies we encounter? One is postpartum hemorrhage. This is the most common one. More than 70% of the obstetric emergencies are because of postpartum hemorrhage. Antepartum hemorrhage, eclampsia, severe preeclampsia, uterine rupture, sepsis, and one more, I want to just add a few words on perimortem cesarean section. So anesthetic management, as already been mentioned by my previous speakers, the types of PPH can be primary or secondary. The PPH is because of causes are like trauma, tissue, thrombin, and inversion. So secondary causes may be retained tissue and infection. Then fluids start, most of the time start ringer-lactate better than normal saline. It improves the peripheral perfusion while maintaining oxygen delivery. Excessive crystalloid resuscitation can result in dilution and coagulopathy and decreased oncotic pressure, so leading on to pulmonary edema, especially in cases of eclampsia. So before going into any of these, we have to know the physiological changes which have occurred during pregnancy. So these may mask diagnosing the urgency of PPH when we are seeing in these cases. So allow permissive hypotension, mean artery pressure of 50 to 60 millimeters of mercury, And this decreases the multiple organ dysfunction syndrome or ARDS. Next, coming to, and it also increased IV fluids leads to decreased concentrations of fibrinogen, hemoglobin, and platelets with the prolonged PT and APTT. And massive transfusion protocol activated, more than 1000 ml blood loss is there. And cryoprecipitate or fibrinogen has to be given at 2 to 4 gram, has to be maintained at 2 to 4 grams. So more than cryoprecipitate, most fibrinogen replacements are done with cryoprecipitate. And use of tranexamic acid within first 3 hours has better results. If recombinant factor 7A is available, can be used for refractory blood loss. Drug therapy has already been mentioned by my previous speaker, oxytocin, methogen, misoprostol, carbetocin, and tranexamic acid. Then optimal surgical management for PPH, controlled cord traction, uterine conservation techniques like uterine balloon tamponade, stepwise uterine devascularization like pelvic vessel ligation, uterine compression sutures, and hysterectomy has to be planned. Damage control surgery indicators of are like hypothermia, maternal blood pH less than 7.1, systolic blood pressure less than 70, persistent bleeding despite massive blood transfusion, and base deficit of more than 8. So radiological procedures like uterine artery embolization, internal iliac artery embolization, balloon occlusion, or resuscitative endovascular balloon occlusion of the aorta can be done. Key goals of anesthetic management in eclampsia and preeclampsia is seizure control, blood pressure has to be maintained between systolic between 150 to 160. Volume status has to be maintained. Don't overload these patients for the risk of pulmonary edema. Lab investigations like platelet count coagulation to rule out HELP syndrome. And airway, always anticipate difficult airway and keep things ready for difficult airway management. Monitoring, always invasive blood pressure monitoring if possible. Urine output has to be monitored. Next, coming to anesthetic management of uterine rupture. There is sudden severe abdominal pain, vaginal bleeding, cessation of uterine contractions, fetal bradycardia, and maternal tachycardia or hypotension. Again, anesthetic goals are maternal resuscitation, fetal rescue, rapid surgical access like enable repair or hysterectomy, minimize awareness, use balanced anesthesia. Special consideration is general anesthesia is preferred if, due to urgency and hemorrhage. Regional anesthesia is contraindicated in hypovolemia. Be vigilant for airway edema. Early involvement of multidisciplinary team of obstetrics, anesthesia, hematology, and critical care is very important. Next, coming to anesthetic management for antepartum hemorrhage. Again, it depends on the primary survey, have IV access, high flow oxygen, fetal monitoring is viable, lab investigations to be done. Next, obstetric considerations, where do we expect antepartum hemorrhage like in placenta previa, abruption, vasa previa, and uterine rupture. Post-operative patients may need ICU care and they have to be monitored for coagulopathy and renal injury. Uterine tone assessment has to be done, pain control. Then sepsis is one of the most common problems in obstetrics. So definition is a life-threatening organ dysfunction which is caused by dysregulated host response to infection in pregnancy. The red flags are heart rate of more than 100, respiratory rate of 20 per minute, mean arterial pressure less than 65, mental status, oliguria, high lactate and coagulopathy and thrombocytopenia. These are the antibiotics which are used. So vasopressor support has to be started as early as possible and ongoing fluid loss has to be replaced. And what is anesthetic management in perimortem cesarean section? Is performed during maternal cardiac arrest ideally within 5 minutes of arrest, which optimizes maternal resuscitation and fetal survival. It's also called as resuscitative hysterotomy. So it is performed under ongoing CPR. So there is no time for formal anesthetic induction. It should not be delayed for anesthesia preparation. Patient is unconscious from arrest, so go on. So aortic cable compression impairs venous return. So as early as possible, baby has to be delivered. So just 1 minute. Can I continue for a minute? Yeah. So fetal survival possible only if it is delivered within 5 minutes. So the extraction of the baby improves chest compressions and also the hemodynamics. So surgical consideration, it can be done at bedside in ED or wherever the arrest occurs. So with a midline incision. So if patient gets back ROSC, then you can think of anesthetizing these patients. So according to this is ACLS BLS protocol for peripartum cesarean section. So if does not occur within 5 minutes, always consider perimortem cesarean delivery. The neonate should be evaluated for neonatal resuscitation. So pearls for safer practice are always have plan B or C, convert early if unstable, simulation drills saves lives, and clear documentation and structured handovers are important. Summary, obstetric anesthesia have high stakes and they are fast paced. Be surgically prepared, think ahead and communicate early. Be prepared, stay calm, act fast. So, thank you. This is my institute, JSS Medical College and Hospital, Mysore. Thank you.